So when we're talking about treatments for higher risk myelodysplastic syndromes, the first thing we need to do when we see a patient is determine whether that person has lower risk MDS or higher risk MDS. We do that by using the International Prognostic Scoring System, particularly the revised version, which we use as a default staging system for myelodysplastic syndromes. And this used to be fairly straightforward. We base our assessment of a patient's risk on that person's blood counts, their blast percentage in their bone marrow, and their cytogenetics. Patients who have a lot of cytopenias have a relatively high blast percentage, so above 5%, and particularly above 10% up until 19%. And those who have poor risk cytogenetics, particularly those who have complex cytogenetics, would fall into higher risk categories. Now, with molecular typing, it's thrown a wrench into the system because we see patients who might be classified as having lower risk MDS using the IPSS or its revised version, yet have poor risk molecular profiles that might include, for example, P53. So with higher risk MDS, no matter how we define it, the standard of treatment is usually to use a hypomethylating agent, and that can be either azacitidine or decitabine. More recently, we have an oral version of decitabine that's been approved that seems to be about equivalent to in activity to azacitidine or decitabine, though we haven't had any really great head-to-head comparisons among the hypomethylating agents.